Welcome to AZENT's Guideline Updates, episode G13, Dyslipidemia. I'm Dr. Z, and with me is KC, one of our internal medicine residents working through outpatient clinic this month.
Glad to be here. Cholesterol is the thing I get asked about at every single visit, so a brand new 2026 American College of Cardiology and American Heart Association Dyslipidemia Guideline caught my eye. What is the headline?
The headline is that the guideline moves toward lower goals and a more personalized way of deciding who needs aggressive therapy. It folds in newer risk markers and brings the PREVENT risk tool into lipid decisions, the same calculator the hypertension guideline now uses.
So statins are no longer the whole story?
Statins are still the foundation, but the guideline gives you a clearer ladder of add-on therapies and sharper tools for deciding who climbs it.
Start with risk, since you mentioned PREVENT.
Right? For primary prevention, we now estimate risk with PREVENT, which stands for Predicting Risk of Cardiovascular Disease Events. It replaces the Pooled Cohort Equations. It is race-free, and it incorporates kidney and metabolic factors. The estimate drives how intensively you treat.
And when the risk estimate is borderline, how do I break the tie?
Two tools the guideline elevates. First, the coronary artery calcium score. A calcium score of 0 can justify holding or deferring a statin in a borderline patient, while a high score pushes you to treat. Second, lipoprotein written Lp(a). The guideline recommends measuring it at least once in a lifetime because it is genetically determined and a powerful independent risk marker.
Anything beyond the standard cholesterol panel?
Apolipoprotein B, written ApoB, gets more attention as a measure of the total number of atherogenic particles, which can be more informative than LDL cholesterol alone, especially in patients with high triglycerides or diabetes. And the guideline reinforces screening for familial hypercholesterolemia in patients with very high LDL or a strong family history.
Let's talk goals. Did the LDL targets drop?
They moved lower for the highest risk patients. For secondary prevention, patients who already have atherosclerotic cardiovascular disease, the guideline pushes LDL cholesterol well below 70, and for the very highest risk, toward a threshold near 55. The principle of lower is better, established by the cholesterol trials, is now reflected in the numbers.
And how do I get there? Statin first, obviously.
High-intensity statin first, maximally tolerated. If you're not at goal, step 2 is to add ezetimibe, which is oral, inexpensive, and well-tolerated. If still not at goal in a high-risk patient, step 3 is a PCSK9 inhibitor, the injectable monoclonal antibodies, which the Fourier and Odyssey trials showed reduce events on top of statins.
Where does bempedoic acid fit?
It is a useful option, especially for statin-intolerant patients. The Clear Outcomes trial showed bempedoic acid reduced cardiovascular events in people who could not tolerate statins. So the latter is statin, then ezetimibe, then PCSK9 inhibitor with bempedoic acid as an alternative oral agent when statins are not an option.
Statin intolerance is half my clinic conversations. Patients are convinced statins cause their aches.
Common, and the guideline takes it seriously without surrendering to it. Many reported symptoms are not truly caused by the statin, which blinded trials have shown. The approach is to re-challenge, try a different statin or a lower or alternate day dose, and only then move to non-statin therapy. Do not just abandon LDL lowering because of one bad experience.
And the adherence problem in general?
Huge. The best regimen is the one the patient takes. Simplify where you can, explain the why, and use the absolute risk reduction to motivate. Coronary artery calcium imaging can be persuasive for the patient who thinks they do not need a statin at all.
What about high triglycerides?
Address secondary causes first: alcohol, uncontrolled diabetes, certain medications, and lifestyle. For very high triglycerides, the concern is pancreatitis, and you treat to lower that risk. In selected high-risk patients on a statin with persistently elevated triglycerides, icosapent ethyl has a role based on trial evidence. But the primary lever for atherosclerotic risk remains LDL and ApoB lowering.
And the patient who just barely qualifies, the borderline primary prevention case?
That is exactly where the personalized tools shine. Use PREVENT for the base estimate, then refine with coronary artery calcium and lipoprotein(a). A calcium score of 0 may let you wait. A high score or a high lipoprotein(a) tips you toward treating. It turns a coin flip into a reasoned decision.
Let me bring it together. Risk now runs through PREVENT, which is race-free. Refine borderline decisions with coronary artery calcium and a once-in-a-lifetime lipoprotein(a), and use ApoB for particle burden. Goals are lower, well below 70 for secondary prevention and toward 55 for the highest risk. The latter is high-intensity statin, then ezetimibe, then a PCSK9 inhibitor, with bempedoic acid for statin intolerance. Re-challenge before you give up on statins.
That is the 2026 guideline in a nutshell. Lower goals, smarter risk assessment, and a clear stepwise path of add-on therapies. The science of lower is better finally written into the targets, with the tools to personalize who needs to get there fastest.
Lower goals, better tools, a clear ladder.
Exactly. This episode is educational only. Thanks for listening to AZENT's Guideline Updates.